Welcome to the 15th annual Flanders Family Visiting Professor of Medical Simulation, and welcome here at the General and to our sister sites around the McGill network. I'd like to thank again Cappy for the advanced thought of having this visiting professor in medical simulation. I think it's a unique opportunity. It's a unique visiting professorship in medical simulation in North America, and it's an opportunity to bring people from very various backgrounds to talk about things that are important for us with respect to simulation. In the past, we've had neurocognitive psychologists, we've had nurses, we've had physicians, and of course we've had surgeons. And today I'm happy to say that we have another surgeon to perform this talk. Today's visiting professor is Dr. Robert Sweet. I've known Rob for a number of years through the work with the American College of Surgeons. Rob is a professor of surgery at the University of Washington, and his area of clinical expertise is urology. That's obviously not why he's here today, of course. Rob is head of the Center for Simulation at the University of Washington, and also head of a large research program there that encompasses engineers and a lot of different elements to bring simulation sciences to the forefront. In particular, he is the lead author on what is called the Advanced Modular Manikin, which is the fruit of a large Department of Defense grant. And I think one of the things that we've always talked about in simulation is that it's not about the technology, but of course sometimes it is about the technology, and there are a lot of things that we can't do because the technology isn't there. So Rob is going to talk to you today about some of the advances that they've been able to bring and things that I think we would be looking at to try to adapt here. So I'd like Rob to take the table and come on.
Thank you, Kevin. Thank you, Cappy, for this opportunity, and thank you all for attending this morning. I'm coming to you from University of Washington, Seattle. The weather's much different there, though this is very familiar to me, being really a native Minnesotan. And this presentation, I'm actually, in a way, representing Minnesota because I still have a 10% appointment at University of Minnesota to complete this particular project. This project started before I transitioned. And it represents, I think, potentially a big shift in our capabilities in using simulation in healthcare, and I hope by the end of this talk you also feel that way. So a couple disclosures here. I did start a small company that builds small modules right now, kind of focused on urologic modules, but none of the things that I'm discussing today have to do with this. In fact, the Department of Defense, a U.S. Department of Defense, actually made this project a requirement that it was open source. So this is an open, the things I'm going to be presenting are open source, and they're going to be available for the public so that we can advance the field, and that's the whole point. A separate project that I'll be mentioning here is an advanced airway module. We just won a Phase 3 contract with the DoD for our anesthesia colleagues here in the audience, if there are anyone from ENT or anyone who's doing surgical airways or advanced airways. It'll be hopefully something that you might be able to use in the future that the DoD is invested in. So I like to talk about what our field really, and I assume many of you in this audience think of simulation in healthcare as a primary driver in your career. At least it's very important and embedded in your education, your whole ethos, so to speak. You have an amazing history in education here at this institution. When I'm talking to the public about it, I talk about it as a disease, and the disease that we're treating is medical errors. And many of you have seen this, the third leading cause of death in the United States. And so, we need to pay a little bit more attention to it. And simulation isn't the only solution, but I believe it is part of it. And then I guess you have to ask everybody, do we really treat healthcare as the high-stakes profession that it really is? in the airline industry, in the nuclear power industry, and submarine industry. And this is why the DoD has invested a ton in this, is they understand the value of practicing before you do in these high-stakes professions. They're very similar to what we do in that we have responsibility of other people's lives in our hands, just as they do. And it combines crew resource management and technical and non-technical skills, equally important in order to have good outcomes. We all know that. But there are a couple differences here. One is our own life, maybe our reputation might be at stake, but our own life isn't at stake, whereas these other individuals, they're the first to the scene of the accident often of the times, as driving a submarine or airplane. The other thing that I think try and temporize some of the expectations in those of us who are doing development in this area is that we didn't design the human body. We designed the airplane and submarine. So we understand the materials involved and how different physical environments can affect how they may behave in the environment. We still haven't defined the human body from head to toe completely, and therefore it's hard to simulate what you haven't defined in the real world. And some of the research we've been working on has been attempting to do that and fill some of those gaps. So really, the reason we're all here is to ensure that we're prepared, when this happens. And what is it that we're ready to do, whether it's ourselves, that we're prepared personally, and our teams, and the infrastructure around us are all ready when this happens. And the first thing you need to understand is the surgeon themselves prepared? Do they have the confidence, they have the knowledge and skills to manage this? Is anesthesia prepared? Is there good communication, decision-making, technical skills, and even in the affective domain, which is controlling your own emotions when this happens? And it's rare, but when it does, are you prepared? And I don't need to tell this audience about the importance of technical skills. Really, do we have very good objective means of assessment to do that? And I think for basic skills, clearly that was pioneered here, and we continue to do that. But we still don't have a really good simulation system or training system other than work or practicing on people when it comes to the complex surgical procedures that we do. Even some basic fundamental technical skills, we still don't have fantastic models once we get to more tissue-specific and partial task trainers. Jerry, you're in the audience, and again, a pioneer in this area, and FLS is extremely important. We've adopted that for in urology as well, and I know gynecology is doing it. And again, this mistles and very, very important to what we're doing. What I'm hoping is we can continue to move this forward and offer more opportunities and expand capabilities in more of the technical and non-technical skills for surgical procedures. So are there any residents in the audience here? Do we know? Great. Wonderful. And fellows, medical students, and even some junior faculty. I think I spent a lot of time looking at this. This is basically a combination of Dreyfus and Dreyfus's model and Dave's taxonomy for psychomotor skills, and kind of lay them over each other. And if you look and think about any of the particular tasks that you're doing day to day as you're learning them for the residents and fellows, you can kind of look and see what's happening in your brain as you continue to go across this. And also, I think the most important thing with this is understanding when you're able to get from that sort of precision to articulation phase, okay, or proficient to expert. And the reason that's important is we multitask all the time, and I think that's when a lot of our errors are happening in the OR. And we've seen it in a lot of the learning curves in the literature we see where you're going up like this, and there's this little blip before then you go back up again. We see it over and over and over again, and that's our brain saying, I'm ready to multitask, and telling us to do it, but we're actually not ready to multitask yet. We still need cognitive load in that scenario, and that's happening. So, I challenge everyone to look at the procedures you're doing day to day and see where you are, and every procedure might be a little bit different depending on your volume, et cetera, and challenge you to think about, when you're multitasking in the OR for the procedures you're doing. I'm going to transition a little bit to a project we worked on when I was in Minnesota, which is a Department of Defense contract for combat casualty care. And it's important because we were looking at, U.S. Congress said that we had to completely replace the use of animals, live animals, for training. And they told the U.S. military that they needed to do that. And we proposed starting with combat medics and at least exploring the gaps, if there were any, for basic things like tourniquet and chest tubes and chest seals and NPAs and some fundamental things that they do in the field that save lives as it revolves around hemorrhage and airway. And their model that they use now before they deploy, and I believe it's similar here, is they work on a K-prime model or a GOAT model. And that's what they do. It's their only live tissue experience before they're actually taking care of people in the field, the units that are deployed. That's their only exposure to it. And so we were interested in looking at that, and we compared it to what was out there in the market. And we really found that there wasn't a single system that was able to replicate all the things that the K-prime model was able to do. We used different parts. So another thing that was challenging for us, I mean, if you go to the next step, which is trying to do even emergency medicine procedures or surgical procedures, there was really very little to nothing that could simulate those things. And we knew that we were using live animal models for that purpose, especially for new procedures that were being introduced. So we actually wound up making, and we called them Frankenstein, Corporal Frank and Stein, which is a hybrid simulator, and those legs are animatronic legs from one company. That chest you see there is the cut suit, a different simulation company. And we built a platform for which a guy could slide into it, so we actually had a real person talking to you, but you could still do procedures on it. So you could do tourniquet, you could do junctional wound hemorrhage control, chest seal, chest tube, and then for airway procedures, the guy jumped out during a distraction event, and we hooked up a SimMan 3G head, and they could do cricothyrotomy and endotracheal intubation, NPA, a bunch of different things on that. So it required us doing this, and I think the DoD is watching this, and they said, what if we created a platform that allowed all these different companies to interoperate with each other? And that was sort of a seed, I believe, that started some of this concept. And the other thing that was interesting, too, is that, communication skills, we talked about technical skills, 70% of medical errors are thought to be related to poor communication. And I think there are anesthesiologists in the audience today, I think, maybe not. Team Steps is a really important program that came out of the military, and HRQ is taking it on. And our institution now teaches and goes around the country teaching Team Core as one of the important skill sets. And we've been doing that for quite a long time now. And we really believe this is in some ways even more important for that original scenario I showed you where that Highland was bleeding. And so it's about closed loop communication, team formation and reformation, and handoffs, recognize them, practice skills. I can't tell you how important these things are, and we continue to teach them across the system. We actually took these and we did a study through the HRQ grant looking at obstetric emergencies, specifically crash C-sections, and this was published in the Joint Commission Journal. We looked at 3 different hospitals prospectively for their perinatal morbidity and mortality. One of them we just followed. The second one we did Team Steps didactics program. And the third one we actually did applied Team Steps using simulation in an in situ environment so that the teams could practice all the handoffs involved in a crash C-section. And you can see here that only one of the hospitals really, the one that got the simulation, which is the dark line here, immediately after the intervention, we dropped perinatal morbidity and mortality 37% at that hospital. The other two, there was really no difference. You try and do didactic for these types of behaviors, it might last a week, and then they go right back to what they're doing. If they see themselves doing behaviors or lacking certain behaviors on video and talk about it in the debrief, they change their behaviors. They have to believe in it, and this is a great example of that. It was interesting. We actually did just standard assessments of how they felt, how safe they felt they were, we saw no difference in any of the hospitals. They didn't know what they didn't know in this case, but we actually changed perinatal morbidity and mortality. So let's transition to the main topic, which is this platform. So the concept, again, of this particular was to crowdsource modular development and make things interoperable. And it's a collaboration. The prime actually is to the University of Minnesota. I'm the PI of this project. The University of Washington is a sub-award. American College of Surgeons is involved, and several companies, including CAE, which is important to this community as well. Obviously, the Department of Defense is involved and continues to monitor what we're doing. The mission really is to create and disseminate an open source platform and standards that facilitate advancement of the field and provides, again, interoperability to healthcare simulation technologies. And if we talk about open source and the success stories, there are so many. It's great to see that this field is starting to move in that direction, because what that tells us is that it's maturing. And it allows, I think, a lot more to happen in the field. And I think a lot of these companies ultimately are going to be more successful by using this platform. And it allows academic institutions such as yourselves to develop things that can go to market easier, because you're going to be focusing your technology on module development, not building a core system. And those of us that run sim centers, we now have a system where things are talking to each other. We can invest in the system, and we don't have to worry about buying mannequin after mannequin after mannequin and virtual patients and all these other things, when they will all actually talk to each other. So what is it? Again, it's called Modular Manikin. In some ways I wish it wasn't called a mannequin, because mannequin's only part it actually is. It's a platform. And it allows for interoperability, and it will boost capabilities, applications. It's modality agnostic. In other words, virtual patients, VR models, data-driven models, physical models. If it adheres to the standards of the software standards and hardware standards, and uses the free open source data sets that are provided, it will connect to Physiology Engine and be able to talk across the system to other modules. So it doesn't matter what modality you're using. So what did we have to deliver? And I'm going to go through each of these. One was a complete male and female anatomic data set. Expand. There are going to be other data sets that come out, but these are the original ones that this will be alpha. So you can be alpha compatible, beta patient compatible, whatever, but alpha and beta as far as male and female sets are released. So every single organ of these patients are available as CADs for people to the community to get, download, and use. And they'll fit into the system. And then we also created, tested, and delivered this interoperable platform and stimulates the community to design these things. We then built, again, this is really important, a universal connector so that all these parts could connect. And it would allow for data, power, fluid, and air without a tool. So those of you that are technicians in the Simulation Center here, you don't need a tool, a special tool to connect and disconnect the system. Then we had to develop a scenario, which I will show you, that it mimics some patient injuries, that shows that we can take the same patient in an austere environment, for example, so that paramedics are taking care of the patient, same patient's getting taken care of and treated in the emergency room, that same patient's going to get treated and taken care of in the OR with teams. And it isn't smoke and mirror teams. I mean, what's happening from one individual and one group goes across the Physiology Engine and communicates to the others at the same time. And that's the key difference from what we have now. We used a Physiology Engine called BioGears, which is an open source physiology engine that the DoD also funded. But that isn't the only physiology engine that can work with this. In fact, we are in discussions with CAE about, and we're actually currently, we're beyond discussions. Actually, as of a couple weeks ago, we're actually developing the capability to take CAE's physiology engine and plop it in here so you can use that. It's field tested and has a lot more capabilities than the open source one does. So if you want to purchase it as a module, you could potentially do that. And then we're going to show you that we integrated and test multiple physical as well as digital models, and the digital and physical models are talking to each other. Different companies, but they're talking to each other, and what you see in one affects what's happening in the other. American College of Surgeons is field testing this now. They've got 3 sites chosen, and they're going to be launching within the next couple weeks the first site, and publishing all results as open standards and open source. As far as responsibilities, I think I went through this mainly. The ACS is mainly doing the formative validation, and the key thing is that the module development on this, ultimately, everyone will be able to contribute to the project, and then people can use what they need. So the first deliverable was to create a male and female anatomic data set. We did this using CT MRI as well as body casting, laser scanned subjects, and we created again a male and a female model, and all the different layers are available. If you want specific organs or specific data sets, you can get them. This is just an animation showing, all the different layers that there are of different models that you might need for what you're trying to build. And we also established specific places where the modules of the body, or segments we call them, can connect. So if you're building something in the chest or the pelvis or the arm or the leg or the head, you can build your module within that footprint, and then you can use the other spaces either for power sources or let other modules do what they need to do for the system. The second deliverable is more for the engineers, but it was the AMM core source code, and this is just the architecture for how it works. We're working across DDS, which allows a lot of data to go from specific modules to help drive and communicate across the system. So, and we break them up into like auxiliary modules and databases, the physiology module, again, things talking back and forth, communicating across what we call the core. And you'll hear me refer to the core a little bit later. So, you remember in the 90s, which is a huge enabler, the USB, the Universal Serial Bus. And this was really a needs-driving solution. So we had a need for some type of universal connector between devices. They were taking up way too much space. Everyone built their own thing. Developers were running out of room, and every device needed its own serial port. Well, that was, again, kind of a driver here, and this was our universal connector that we built for simulation healthcare, which allows modules to attach, again, providing data, power, fluid, and air. And the schematic here is available to the public and for people to use, so they can build this footprint into their system and build these connectors into their systems. And this is one example of an arm one that we had, but it has a casing around it. And here's just how easy it is to connect it and to disconnect it with the push of a button, which is important for the technician standpoint. So there's a spine connector with our system for our demo unit. You can see that network router. You look at how much space there is in the admin. If you've looked at any of the current systems that are out there, it's filled with things, stuff, a lot of electronics. Everything's tucked away in a way so that it leaves open space for anatomy, for things that we're actually dealing with, which is an important aspect of this particular design. We had to do veracity testing on the connector if we're going to put it out to the public. So we looked at, because we're using electrical and fluid for the engineers. Again, it doesn't take an engineer to know that's not a good idea to combine the two. But we did some vibration testing for a helicopter type environment. We did some torque testing, 150 pounds, and then a pull test of greater than 120 pounds on the connector itself. So again, here's one of our early units put together. We can see disconnecting and connecting the system here is pretty easy. This is an airway that connected. You can then put a neurosurgical module, I guess, if you wanted to on it. One of our techs, and she's like this tall. I wish they showed her too, because I don't want to, but take anything away. But the point is that she's able to disconnect and connect the leg and the arm without any trouble at all. The fourth deliverable was, again, integrating this open source physiology engine. So I guess we created a couple new capabilities and we connected it. And this is really why you do this, so that whatever module you build now can have physiology. As long as you build some sensors in, you decide what it is you want to publish or give to the system based on what intervention you're doing and what you want to subscribe to, what things might drive a change in your module. That's how you need to think about it when you're doing your design. and then it'll work, and it's worth making it AMM compatible. Making it just physically compatible, it's not that key. I mean, I don't think you're going to get a lot from the system other than allowing it to play with other modules that do have that capability. The key is thinking about how your module might change physiology, either locally or provide someone else to do so. And this is just an example. There are a ton of different things we can measure. So the different data elements can be communicated across the system to drive behaviors of the module Manikin. And the whole concept here was that we wanted to think of the system as a Manikin as a form of a display of the state of the patient. I mean, right now, the systems that we're using, someone has to tell you, okay, the patient's becoming hypoxic now, or the patient, this is happening now. Whereas we should be able to look directly at the patient, whether it's virtual or physical, and that's part of the learning, is recognizing that there's a problem, as opposed to someone telling you that there is one. So deliverable 5 was to actually successfully integrate modules from various vendors, and here's just some examples, and I'm going to show these. An abdominal palpation module, that's an independent company. CAE, we integrated their ultrasound fast exam in the system. Symmetry is a company that the DoD funds down in Florida. They built a fasciotomy module that's compatible with the system. Our lab, CREST, built 3, one for advanced airway, a laparotomy module, which I'll show you, and a fluidics module. And then VCOM 3D show that we can have a virtual patient also running in the background that's communicating. And also they built a virtual ventilator and virtual IV pump. So anything that you may not even exist right now in the physical world, you can still have potentially in the virtual world. And it allows distributed training and learning and assessment capabilities as well. So there's value to the virtual patient. So let's talk about our patient here. So we had to do a demo, and this is what we're preparing. We've done an alpha demo already, DoD, and we have a beta one coming up in January. And again, we had to show that the system works across different environments, or they call roles in the military, as well as different levels of provider. And our patient's a 28-year-old male involved in a motor vehicle crash. So you're going to see some gore here in the presentation a little bit, but it's all simulated. Nothing's real here. Again, the same patient's getting field care by the paramedics, resuscitation diagnostics in the ER environment, and then team trauma care in an operative environment. I'm going to show a series of schematics here, and the spine here represents the core. That's the platform. And so let's explain what's happening, and I'll show you it kind of happening. So when you connect the system, in this case the virtual patient, to the system, it says and it recognizes and identifies and does a handshake, so to speak, with the system and says, okay, I know that system is now connected. And then it looks for what it's looking for from the core physiology engine. And in this case, this patient is in pain and has early hemorrhagic shock. That's the state of the patient. And so it communicates back because this particular module is asking for what things, pain specifically, and a state, in this case hemorrhagic shock, and the patient will voice pain and start displaying the signs that are in symptoms. So this is that module. There's no sound, it doesn't sound like, but he'd be moaning right now. But again, a virtual patient that, again, is communicating with system. So then there's a physical IV arm that you can connect, and that system's part of the airway module. This one's very interesting because, again, it recognizes when you connect it, but then when you correctly actually place the IV, a sensor recognizes that you're in and tells the physiology engine and the virtual patient, so IV just shows up on the virtual patient. Two different companies, but it says I want to know when it's there. It was right. If you don't put it in right, it won't show up on the virtual patient. And then you go ahead and you can start giving fluids. It recognizes that and automatically talks to the physiology engine. So you know the rate that's being provided of resuscitation. Physiology engine changes, but then it says the physiology engine says this is what the heart rate is. It then talks back to the arm and says the heart rate's now 90, and you can feel the pulse on the arm that's 90. So the point of that is that the arm itself doesn't have that capability, but it's the asking for information from the physiology engine. So there might be someone else's leg that's also bleeding, that's also contributing to what's happening. The point is that all that arm's going to see, it's going to be a common pulse across both of them. That makes sense. So here's a little puck in the IV arm. Again, it's part of our advanced airway trainer. Here one of our admission technologists is putting in an IV, connecting it, providing fluids in this case, and it's affecting what you're seeing in the physiology engine, and you're going to see on your physiology ultimately. So the next module is an abdominal exam. Again, a different company made it, and they decided to make it compatible with the system. So they built a connector, and this is a physical model that's compatible with the system. And it was built specifically to teach abdominal exam. So in this case, what we wanted to do and show is that when you do the abdominal exam on the patient, and you can go ahead and connect it easily into the whole system, again, that there's pain that's being represented when you're supposed to have pain with that particular exam. And so in this case, it recognizes it. It does that very thing. So again, here's our technician clicking their system in. Pops in, and then we put the skin up of it, ultimately, once that's done. This is with the abdominal connector, a little bit different than the extremities or segmental connectors. Wish there was sound here, but basically, I don't know if you can, it's subtle, but there's some balloons in here, and here's our breathing mechanism working on this mannequin, and you're doing an exam on this particular model, and he'll moan when you're reaching, in this case, we do rebound, he has pain. And the way that works, again, is it's talking and saying that there's a pain signal, and the virtual patient's actually giving you the pain response. Two different companies working together without actually talking to each other. So then the next one we put in there was CAE's ultrasound fast exam model. A very similar scenario here where are you familiar with that? I assume you have that system here. Same concept here. You can go ahead and do fast exam on the same model. He's still breathing. If you push down on it, you still get the pain response because the Octet abdominal exam simulator's in there, so you'll still feel it just like you would in real life. And there's some fluid around the left upper quadrant in this case, and this patient's unstable, so ultimately they're going to be going to the operating room. So they go to the operating room now, and what we're going to show you is that we're going to swap out that abdominal exam model patient and put in a laparotomy module. Connect it so that when you lose blood in the system, it communicates with the anesthesia system. But before that, we need to intubate the patient, and anesthesia does that. They provide drug administration through that arm. And once those drugs are present, the airway and the patient will stop breathing, and you can go ahead and intubate, and sensors will tell you whether you're in the right place or in the wrong place. You can do bag valve mask or esophageal intubation, and you will see the physiology of each of those if you do them automatically. You don't have someone behind a curtain changing it because one thing happened or another. It automatically happens, and the patient will respond accordingly. And this is one of our early pictures of the airway. Again, trying to improve the state of what we're doing and some of the fidelity of the system. Here's another picture of that. Again, we're going to do VVM here, intubation, and he'll do an esophageal intubation. The chest won't rise. You listen. We actually have a stethoscope you can hear that's all virtual. You can hear whether there's sounds in the stomach if you're not in the right place, or you'll see unilateral chest rise or bilateral chest rise if you're in the right. Again, talking through the system automatically. So again, I mentioned this already, but with the laparotomy hemorrhage control module, when you're giving fluids and it's affecting the pulse, you will see that in the operative field. If you're losing blood, the anesthesiologist will see that you're losing blood, and so the two are working together, or 3 or 4 of you really as a team. And here's just the module itself. Rob Rush is doing control of this particular patient. We're doing this as a separate system as an independent module, but then we connect it to the system. And we've developed artificial tissue plates that we can swap in and out that allow us to do the procedure. And we're focusing on developing pucks, small pucks, so that instead of placing an entire spleen, you only replace the part that you're destroying, just the little vascular pucks that you're gaining control. And then we have recipes for fat and connective tissue, which are really, really key in surgery, right? I mean, that's really where we're operating most of the time. And we have templates that we show the tensions on where to reset the model every single time. And it's going to be going through the field testing very soon with the college. So here's just some, again, a pilot at our institution. Dr. Sachdeva and Raj Agarwal, one of you guys know Raj very well, obviously, and Dimitri Stefanidis came and visited us. And we ran through a pre-pilot here where we kind of tested the system, made a couple tweaks, and now it's going on the road. Again, here with the IV arm, you can see vascular control. In this case, team training all with the anesthesia and surgery with the system. Wouldn't be complete, as you had to put one urologic model in there. This is a trauma cystography model that we created. Then I can talk to my peers. Otherwise, and I had to twist the DoD's arm and make sure, because I don't think they prioritized it, but I went forward with it anyways. But it's just a swappable bladder, so you can connect it and disconnect it once you've tested, and then you can test it for leak. It automatically has sensors in it, so it knows if there's a leak or not. And then again, physiology will respond, labs will respond, and the team can respond. So a little bit about the female side of things. Just the DoD started to recognize that some of our female soldiers were dying of preventable trauma, and one of the reasons they think was for that was that they were there was an issue with exposure, so chest trauma, and that male soldiers were trained, you don't look at the chest, you don't touch the chest, and no matter what. And I think they were actually missing certain entry wounds, exit wounds, and so they wanted to sort of do some emulation of that with the system. So they thought it was really important to develop a female trauma trainer, especially around chest injuries. So you can see here our fellow, our ACS fellow, and he's a general surgeon, a hepatobiliary surgeon, but he just put a needle decompression in this female Manikin system, again using the same airway model. Everything's the same here. So when you put it in, a sensor detects it. You actually get a whoosh of air when you're in the right spot where they're doing this sort of chest tube, and you automatically get the chest rise bilaterally again. Again, there isn't someone behind the scenes pushing a button to make things happen. If you do it right, you see the response you're supposed to see. So what's next? We don't have a lap model quite yet, but I think we can build one. We're using our laparotomy module, which doesn't seal our pneumoperineum very well, obviously, but it's not a big stretch to imagine we could easily do that. And here you can see actually two of our fellows working together. One of them is playing anesthesia, and the other one is the surgeon, again, getting some vascular control in this particular case. And they sew up the bleeding vessel. And again, the anesthesia is changing here. They're communicating, and that's the point, is that they're focusing on how you communicate around the system or around the scenario. And again, in this case, the patient. So it's important to understand measuring, and just a couple other technologies I wanted to mention is we're building modules. One is when surgery, it's really important to measure what's happening to the tissue itself. And we've really focused on the technique, and that's where we all kind of sometimes disagree. Would you agree with that? Where we all don't agree on how much something might happen, but no one can argue with the results and with what's happening to the tissue. The tissue doesn't lie. If you're not handling the tissue well, it won't do well. Anastomosis is going to break down, or it's going to leak, or it's not going to be patent. And so one of the ideas we had was to embed hidden markers in the silica tissues that we're working on, so that when you in this case do a flap, you will be able to quantify that performance and compare it to experts. So what we did is we put these hidden markers, so when you shine a black light on the marker when they're done, as you see here, you can actually quantify that performance when you compare the pattern that you see compared to a group of experts. And we did that in this case with reconstructive procedures. Here's another example of that in a urologic model, but this can apply to any type of plastics concept where you get tension across wounds, for example, or if you're looking at, you need to line things up. This is a piloplasty model that we built that the AUA used in its courses, and we wanted to measure whether or not it was patent, whether it leaked, and whether the lines lined up. And we're shining a black light on it, and you can see how things are either twisted or they're, and those are the important metrics. We've built, again, we talk about the Manikin as the state of the patient, some skin modules where with different temperature, for example, or light, it changes color, which is really interesting. So it allows us to represent different, again, states of the patient with external stimuli. And we've been working on that as well and trying to embed in some of the modules. Sorry for this as a urologist, but this is an important one for nurses. Putting a Foley catheter, an extremely common thing that we do. We built this module to help improve and understand the different friction forces and understanding when to continue, when to stop, get some help, and then develop male model, and we're developing a female model as well. This one's going to be going to commercial probably within the next 6 months and be available out there. We talked about these morphing wounds with different things. So here's pressure, for example. A hammer's going to come in here, but it's more for comic. But if you go ahead and now you can see there's a little bit of a bruise here with pressure. You can see a little bruising here. Here's a case with light. If you shine a light on this particular skin, it will change different colors, so you can create different moulage situations. And this is, we're using a heat gun to create again a rash in this particular skin. Here's the light coming in, again changing how that silicone is reacting and the color, again what you might get displayed. Pressure, light, and heat all changing, external factors changing how it's going to be displayed. Another key thing is in the tissues is building materials that can measure force. This is a material that as you stretch it, it actually changes color. And so again, we might be able to quantify certain forces happening in these tissues and give us feedback on what that pressure is as we embed in the tissues themselves. So what's the tension across that anastomosis? We might be able to, again, quantify something by looking at the tissue. This one's a little gross, and I apologize, but this is a module we created that connects to the Advanced Modular Manikin Phase 1 system. So this is a burn patient, again, simulated, nothing's real here. We're doing a trauma asterotomy to open up this compartment. There's here, as soon as you cut across those sensors and you adequately expose this, the pulse automatically comes back and then it's from blue to pink. So it kind of combines all these technologies I just showed you, because there's a heating element that heats that hand, that gets turned on, that's the color change, and those sensors just triggers the pulse to come back. And those are the signs you did it. The pulse comes back and the color starts to change. So again, I think sort of showing this all coming together. And that's just an arm you connect instead of the IV arm or on the other side to the system. So now we're entering that sort of validation or field testing phase. Again, we released Dr. Sachdeva through a sub-award, released the RFP to 92 accredited sites. 3 were selected. I think only 2 are going to complete it because we're running out of time. And so I believe San Diego Naval and Sea Stars are going to complete the field testing protocol at this point. We've created an AMM portal. I mentioned that it's available to the public. This is how you gain access to it. Again, because you have to publish all these results. You can either get it through the University of Minnesota or University of Washington websites. So thank you very much. This has been a pleasure and an honor to be here, and I'm happy to answer any questions. Thank you.
Any questions from the field? Dr. Freed?
Rob, first of all, thank you for an amazing presentation, and I think this is it's spectacular what you've done. My question really is about the business model when you start to take away the proprietary role of IP or technology. there's obviously some tension between companies that want to generate revenue by protecting their information versus the open source platform. Do you see there any risk in that regard?
None, because the company's individual modules, other companies don't need to see their IP. That's the thing. So the only thing that's being released as open source is core. So companies are going to make their money on modules. And because the way we set it up, that they're independent and they don't need to have information about each other's modules across the core, it actually stimulates a better market, a broader market. So I think they're starting to understand that. I mean, early on, I got a lot of concern, especially the medium-sized companies. The big ones got IC, and they get it right away. They see, okay, they understand how the open source concept opened markets. The medium-sized ones that have a manufacturing process that's very established, they're nervous because this sort of breaks that mold. It makes, because now they have to start building smart modules as opposed to what we call dumb ones that don't have any sensors in them. If they really want to be part of the system, having one that can't either provide information or get information doesn't add much. And so they're a little bit nervous, but I'm okay with that because it's going to push the technology, I think, give us what we really need. Is that...
What do you think your biggest challenge is going forward as far as simulation?
Are you asking from a market standpoint or a technology standpoint? I think it's the tissues. I still think, we've been working hard on character for surgery specifically, and frankly anesthesia. Anything where there's intervention going on, there's a massive gap, and it's so basic, which is amazing to me. We've defined anatomy. We've defined physiology. We're talking about that airplane. We didn't build the human body concept. We still cannot characterize simple soft tissue deformations. Very simple ones we still struggle with. The physics behind it is challenging. And then to represent that in real time, and then to do destruction models where you're cutting and clipping and that's why VR's got a long ways to go. There's a big hype again about VR. We've built VR modules, but I just know what it's going to take to get the deformations right, and we're so far away. It's just a huge opportunity, and that data is so valuable to you, what you're doing, and to anyone focused in this area in medical device. Understanding how tissues behave is a critical gap, I think. Again, along with what Jerry was saying, I think it's going to drive the cost down because instead of having to buy a complete separate system for every little thing that you want, and then they don't communicate, you can have one system and have interswappable pieces. So you're only buying, from just a hardware standpoint, one element of it. In a way, I believe it's going to drive costs down and increase the applications because you're going to have one common physiology engine. Does that make sense? Well, those are module specific, right? So that's not, again, the advanced modular Manikin platform is the software is free. What individual companies do with their specific modules is, I'm not even going to guess what they're going to do, but just if you think about it, if they're only having to make an arm or a liver versus a whole chest, that in and of itself is going to drive costs down. And so the only thing that might drive costs up is the integration of sensors, but as we all know, sensor technology is getting cheaper and cheaper and cheaper, smaller and smaller, and easier to integrate. We're 3D printing sensors now in materials. I'll show that in a later lecture I think I'm doing, but I think the costs are going to go down, actually.
Any other final comments, questions? Well, Rob, I'd like to really thank you for coming. It was a great talk, a lot of potential. The only thing I would add, if I remember from Frankenstein, is that it came back to actually kill the creator. So I don't know if you're nervous about that. There is a special session on simulation and education technology at 2 o'clock at the Simulation Center. We have 5 panelists that are going to be speaking, of which Dr. Sweet will be one. So you're all welcome to the session. All right. Thank you very much.